In the last session, we have discussed about the method of history taking. Today, I'll be discussing an introduction to neurological examination. Neurological examination is a complex, challenging assessment, and mastery is crucial. But an organized, systematic approach is sufficient to avoid errors, and you can learn through practice, and consistency is the key. There is no universally accepted sequence of examination, but today I'll be discussing better to do in the following sequence: A. Mental status, B. Cranial nerve examination, C. Motor system, D. Reflexes, E. Sensory system, F. Coordination, G. Gait, and finally signs of meningeal irritation, that is skull and spine. Even though in some books motor system examination is divided into bulk, tone, power, reflexes, and coordination, including gait also, that is what I said, there is no universally accepted method of examination. Going to the components of the neurological examination, first is mental status. Assess the level of consciousness. See whether the patient is conscious or drowsy, or whether he is oriented in time, place, and person. Check his memory, immediate and recent memory, and remote memory. And check the cognition. The details of cognitive functions were discussed previously. And during the examination, mainly you should look for signs of confusion. Is the patient responding with the customary clarity, whether he is confused? And specifically look for the orientation in time, place, and person. And think about some evidence of any cognitive impairment is there. Going to the cranial nerves, evaluate the function of 12 cranial nerves, but specifically look for visual acuity, extraocular movements, facial sensations, movement of the or deviation of the angle of face, and the swallowing function. Coming to the motor system examination, you should evaluate the bulk of muscle, tone of muscle, power of muscle. Each one we will discuss separately. Inspect for evidence of atrophy or any deformities or involuntary movements. Then coming to the reflexes, assess the deep tendon reflexes. It is mandatory to examine this. And look for pathological reflexes, especially the Babinski sign, the inverted supinary jerk, etc. Coming to the sensory examination, evaluate the sensory modalities of light touch, pinprick, vibration sense, and position sense. Look for areas of hyperesthesia, anesthesia, or any other abnormal sensations. A detailed sensory examination is unlikely to give value if there are no symptoms. Converse is in case of motor system. Even when there are no symptoms, there can be findings. For example, a patient can have significant spasticity and hyperreflexia even though he has got no weakness. Going to the coordination is in the past part of the motor examination. Observe fine movements, fine motor skills like this as the patient do. Okay. Look for rapid alternating movements, that is datacokinesia, and point-to-point movements, that is the finger nose, finger test. Check for dysmetria and intention tremor. The major coordination is by cerebellum, and the cerebellar findings can easily be remembered by the mnemonic hand tremor, which we will discuss later. So even though cerebellum is the major organ for coordination, the motor system, the sensory system are also involved in coordination. Regarding the gait, assess the patient's ability to walk and maintain the balance. Look for various abnormal types of gait. Make it a point to examine, especially patient coming with giddiness or vertigo, you have to examine the gait properly. So the minimum neurological examination can be completed in 3 to 5 minutes. Focus on essential components and screen for neurological abnormalities. And describe the findings clearly and document it. In conclusion, neurological examination is critical in diagnosing neurological disorders. A systematic approach and practice, and especially practicing with consistency, is essential for mastering this complex assessment. We will discuss these things one by one in subsequent sessions. Thank you.